Thank you very much. Thank you very much, ladies and gentlemen, Chairperson. How do you follow that? Clearly, I'm not going to give you any science. I'm not going to give any statistics. I'm going to give you a flavour. And of course, the North East is becoming the robot centre. Joel's taking up robot as well. So these are exciting times. I love minimally invasive surgery. There's no doubt about this. I believe anybody who has a small enough tumour, it should come out through a small hole. That is, in my view, completely unarguable. I'm an experienced VAT surgeon. I love VAT surgery. I was well trained by Bill Walker. I've done more than 200 cases. I feel very comfortable doing VAT cases. I first saw the robot in 2005 when I did my out-of-program experience, I suppose you would call it, in Leuven. It was in the corridor of the operating room, and we just did a bit of suturing practice, and I thought, this is a completely irrelevant piece of kit. Similar to the TMNR massive machine that we had in Edinburgh at the time, the laser machine for transmyocardial lasering. I thought it would be something that was not going to have any part of our practice. I went for a day course, thanks to Ethicon, to New York. I listened to the same old VAT presentations that I'd been hearing over the last 3 years. They were tired, they were obviously well argued, but I didn't hear anything new. There was a new offering, and that's when I met Franca, who really is the guru, and a brilliant proctor. And she introduced my mind to robotic thoracic surgery. She was not afraid to show the videos that you've seen today of controlling a bleeding vessel. In 2009, we were asked to join a group of robotic surgeons. We had one robot planned. And I remember my discussion with Rex Stanbridge when I was in Hamburg. He had tried the robot, but he hadn't continued with it. What does robotic-assisted surgery add to your practice? Clearly at that time, we were all hearing the danger of having no tactile feedback. We've got everything we need with VAT surgery. Fast forward for 2013, the urologists had been playing at it. I'd seen them at it. And so for 4 years, urology had had Da Vinci 1 in their theatre. The chief executive of our trust requested thoracic surgery to join a group of like-minded different department surgeons with the plan to buy a second robot. I was the only VAT surgeon at the time. Omar has joined me now, Mr. Sembakabachi. And so at that time, VAT and open surgeons, and Bob as a trainee, and a scrub assistant, scrub nurse, we went to Paris and we did cadaveric training for 2 days. And we were certificated after that, having done simulation as well as cadaveric work. You can just about see the that's about my flight, not my wake-up call. You can just about see the Eiffel Tower in the background. So this is on the West Bank. That's Mr. Forty, Jonathan, at the console in the cadaveric lab. And you can see what's going on there. We got a decent feel of it over 2 days. And so we came back to our unit. We started with simple cases. We had an agreement that despite the cost, we would work in a safe principle with decent clinical and risk governance structures in place. And we started with wedge. We started with some bullectomy, pneumothorax stuff. And we basically got the feel of 2 arms. We didn't really need the 3rd arm. The opportunity to learn both on the console and first assist was important. There were always more than 2 consultants in the room, 2 consultant surgeons, and it was helpful to remember the tips. And we built up a series of cases. And the first one we had proctorship for. Then we went to Pisa, and we saw the lobectomy, which is what some of you who are done or planning to do. Again, we took out a decent team. We had 1 lobectomy in the morning, some sandwiches, and a thymectomy in the afternoon. And it was clear from what Franca was saying that there were really no contraindications. Any patient should be able to be managed. There's a no-limit situation. We did our first lobectomy in May last year. We had a strategy that we would attack the lower lobes first, the so-called registrar cases, and we did a right lower lobectomy with proctor present, and we gave the whole day over to that case. We were not going to be pressurized by having anything else on the list. We had the same anaesthetist that we had from the beginning. Presently, we've done 18 months now of robotic work. We've done more than 40 operations, including those wedges. We've done some recent wedges recently because the frozen sections turned out to be TB or something else. Our age group is, we can take on some old uns. 50% of our patients are still smoking. We've got challenging FEV1s and DLCOs. And you can see that we've even done a redo lower lobectomy. Bob was planned to do the 11th case that we did. We found a nodule in the upper lobe as well as the one we knew about in the lower lobe. And we sent both of those for frozen section. They were both cancer. We weren't prepared to do a pneumonectomy. We waited for the final results and in the end went back and did a lower lobe completion. Our skin-to-skin times at first were 300 minutes and the redo was roughly 300 minutes. But we're getting down to somewhere around about 80 minutes. The anesthetic time is between 50 and 130 minutes in my series. Sometimes the anesthetic time is longer than the surgical time. It's not the positioning. And the anaesthetist will say, oh, you take forever. It's not the positioning. That takes tops 15 minutes. Blood loss, depending on what you've done, 20 mils or 2 litres. We've had no major blood vessel leads. So those high numbers blood loss, the redo, lots of adhesions, all vascular, and a patient whose fissure was grade 4, it was completely stuck. And that patient is the bottom one there. He had a prolonged air leak for 14 days, which we felt was due to the fissure being teased apart with the diathermy hook and grabbers. Patient went to ITU eventually, had a bronchopleural fistula diagnosed quite late, but had a bronchoscopy the day before the diagnosis, and that was apparently clear. We repaired the BPF, but he died on day 29. He had a wedge resection on the other side to rule out stuff that was going on there, and he'd had some fibro-inflammatory disease process, and we think possibly he died of a chest infection on top of a sort of inflammatory escalation. The other patient, the top one, she's still with us. Her BMI was 17. That shows you no limits. She was absolutely stick thing. She developed a bronchopleural fistula relatively early, day 6, having had a cough. And she had that re-explored, sutured and buttressed, and she's just trying to get over her 30 kilograms of weight problem. And in an ideal world, we would have optimized her for 3 months before we operated, but targets are targets. Pain score is crucial here. We're looking at post-operative day 1 pain score, and I know it's a blunt tool, but that's all we've got, really. 7 patients had absolutely no pain at all on the night of the operation or from then onwards. 2 patients had high-end scores. One of them was demented, and the other one was confused. Now, I put that in brackets. It might be seen as an excuse, but I think it is a contributory factor. One patient had a high-ish score, but we'd worked out that the anterior utility port had actually migrated onto breast tissue, which is actually quite tender. Most of the others are scoring between 2 and 3. We've opened 2 patients, and their pain scores are naturally going to be higher. This is the lady, the day of the operation. I get them all to do this. You know, I find it absolutely phenomenal that they can do that, and they don't even wince. I'm quite cruel, because I actually do that as well, right? And most of them have no pain. One of us is smiling there. The other one's slightly apprehensive. We've converted 3. Again, not for major bleeding. This is because the tumour was too close to the oblique fissure in 1, which we didn't quite get on the CT. The tumour burst, and it was impossible to pick up this friable lung. It was just becoming a real mess, and I just thought, we'll open. If you go to the Da Vinci website, you'll see these beautiful sanitized videos of pink lung in an 80-year-old lady with not a red cell in sight. And yes, the robot does allow you to do simple operations. And like Franca's videos, this is just going around something. Okay. You want to wait to the end. You want to see whether it bursts, don't you? Malicious lot. But actually, and Franca touched on this, the robot actually allows you to do complex operations. This redo lobectomy, I was confronted with adhesions absolutely everywhere. But we had excellent vision. We had 3D HD vision. And so it was laborious, but we took down every single adhesion, chest wall, every adhesion between the fissure. And naturally, it was a little bit bloody. This is the lingula coming off the pericardium. It's more a case of trying to make sure that we can identify the supraopulmonary vein before we actually move into the fissure and down to the lower lobe. This looked like carnage. The anaesthetist by this time is not looking at their watch, they're looking at the blood pressure, looking at the blood bank, they're thinking, you need to convert. But we knew it wasn't a major blood vessel, and we knew it was stoppable. We just had to find the source of it. The depth of vision tends to go the more blood that's in the picture. There are devices that Da Vinci make for suction irrigation. I have to say I'm not a great fan of them. We would tend to use the striker if we needed to, through a separate port. The striker. This is the same patient, the redo patient, right? With us taking the lymph nodes, ready to prepare for the anterior fissure to be stapled. It shows you the red stuff has disappeared, and we've got good vision again. Now, clearly, as a team, you have to look at everyone's issues. And at the WHO checklist, we give everyone the freedom to say stop if they're not comfortable. The anaesthetists have particular concerns about getting to their tube. Remember, the robot's coming over the top of the patient in an SI system. They give everybody a central line. Everyone gets a muscle relaxant infusion, you'll be pleased to hear. So no patient is waking up with 4 spears in them. And they've got used to, and we've got used to the CO2. The use of CO2 is important. As Bob said in the SETS, we don't really go past 5 millimeters. And sometimes it has an effect on the blood pressure. The anaesthetist has to be fully aware that with 3D HD, even a tad bit of alpha constriction, metaraminal, can actually suddenly make, without telling you what's going on, suddenly make the thing look a lot more redder from the adhesions being taken down, slightly oozy. So there has to be cooperation between us and the anaesthetist. I have obviously listed some surgeon issues as well. Historically, we've had the tactile feedback. People comment about the registrar being at the table, all very dangerous, and the potential for bleeding. I reiterate, you train people well, and you do train yourself well on the console, you should have excellent vision. We've not had any major vessel bleeding. It's quite important to keep the CO2 in. If you have patients, 30 to 40% of patients are coming without any histology, and it's a peripheral lesion, you're kind of obliged to do a frozen section. Particularly, in the last 2 months, we've had 2 TVs. And that frozen section's got to come out of a hole, and the holes that we make are tiny. It's a totally endoscopic procedure. And so I really, really push for a CT-guided biopsy, if I can, because the frozen section is a big enough wedge to make your hole bigger and you lose CO2 that way. The frozen section is a staple line. It's never a soft bit of pliable lung after that. It's actually quite an awkward bit of lung which you're trying to move this way and that. The stapler size is crucial. Again, the stapler is bigger, the current staplers are bigger that we are using than the holes that we would like them to go through. And therefore you lose CO2 that way. As I alluded to earlier, the vision actually shows everything. It's so good a vision that one time when my anaesthetist was not using a relaxant infusion, I could tell him the patient was ready to move because I could see fasciculation of the intercostal muscles well before they had any idea what was going on. I am concerned about the state at the moment. If we have staplers going in and out of holes, there's a possibility you could double barrel. There's a possibility you could have neuropraxia every time you do that. And that's why I'm looking for the all-in-one stapling device when it comes, if it comes. So what is our aim? Our aim clearly is quality of life as well as quantity. We need to reduce pain. We want to have total articulation. We want to have 3D HD vision. We want to have smaller holes. But ultimately, this may all be driven by patient choice, as other parts of medicine have been. I said I wasn't going to give you anything scientific. The potential benefits so far are that I think this will add to us being able to do more complex operations. Patients are either going to have less or no pain. Patients are going to get out of hospital quicker. 2 patients gone home on the second post-operative day with no pain. A further 5 patients gone home on day 3. So it looks as though it's getting that way. We're getting open surgeons who are not comfortable doing VAT surgery, doing minimally invasive surgery. It's extremely ergonomic. Every part of the table console moves. And therefore, back pain for the surgeon appears to be a thing of the past. But our evaluation of this minimally invasive platform continues. Thank you.
Thank you very much, Sasha. Dr. Melfi, can you come back up to the front and we can have some questions from the floor?
Thank you.
Any questions?
Just make a point about cost effectiveness. If you have a robot in your hospital, as I do, we've just gone through specialist commissioning. Lobectomy is not funded, is it? You get the same cost as an open lobectomy, which is a disgrace, and we should all be lobbying to change that as a major barrier to lobectomy. Robotic lobectomy is fully funded, and you get £2,500 disposable costs, while stapler is going to be fully funded. So in our hospital, robotic lobectomy is reaching that. That's lobectomy. So I may not be able to afford to do that any longer.
You are lucky. You are lucky. We are working in Italy, and especially in Tuscany. In Tuscany, we have a similar organization of the Denmark in terms of the Tuscany is divided in 3 different areas. So the government gives some money, additional money on the basis of the studies and the innovations. And we are working to have a very dedicated DRG for robotic, and I believe this is probably the way. Another way is the competition, and we wait for the new system, but this is probably the key to obtain a decreasing costs. I remember, and maybe all we remember when we started with the minimal invasives, with the VATs, the costs were considered impossible to sustain because it was so high. And when the competition arrived, finally we had the possibility to use the system in all hospitals, the VATs in all hospitals. So.
Hi, Franca.
Hi.
I enjoyed your talk. You alluded at the beginning of your talk to the problem of a monopoly, and you just have again now. And it's not just about cost. It's also about driving the advancement in technology, because arguably the technology you're using is 20 years old. We know that Johnson & Johnson have paired with Google to develop a robot, and some of the other big players are coming on the scene. Have you seen any of this technology? And how do you think this is going to change things over the next 5 years or so?
I am an open mind, so absolutely I am waiting for a new technology. Of course, it is clear that if the hospital had an investment, improved this investment, specific investment in VATs, it is clear in robotic surgery, it is clear that we have to compare the 2 techniques. Unfortunately, I didn't have the opportunity to see the Google and to use this, but I'm absolutely in favor of the all new technology, and especially if we can prove as you've seen, it is clear I am really enthusiastic for robotic surgery, but we have to prove the real important outcomes compared with the other techniques. So the first is the patient. This is very important.
Thank you, Franca. I think Tom said in the beginning you are probably the biggest European robotic surgeon. I think you're probably the biggest in the world. So I just wanted to congratulate you and commend you really for all the achievements that you've had in robotic surgery. My question again is based around costs, as we keep discussing over a couple of drinks. How you are in an influential position, Franca, as a council member and a big player within the European, within the EATS, and how can various professional societies, work together to drive competition and introduce new players within the market? Because it is the cost, as you said, is a major issue, and if we are to provide this technique and technology to a much wider group of patients, then the cost will have to come down. Is there any view?
I believe that if the societies, the scientific societies, try to work together and imagine that all the thoracic surgeons works together and they try to have a negotiation as a societies or as group, European group, they try to negotiate to the company. I believe that J&J, for example, if you negotiate as a thoracic society or a thoracic surgeons, all the center with the companies, they have to decrease the cost. We had a similar experience in Tuscany. The Tuscany is organized, has a unique robotic center. Imagine we have 8 different platforms, but when we negotiate just as Tuscany, regional Tuscany, and the cost is decreased a lot. So probably the society can play a very important role in this particular field. But maybe the J&J can answer.
Anybody else?
But it's not more expensive if you've got a robot already. As long as you've got one with urology, everything's covered. All the CRG costs are covered.
If you can persuade your specialist commissioners, but most specialist commissioners will agree to this on a pilot basis, which I think you're doing as well. I spoke to your commissioners. So yes, the commissioners will pay for it on a pilot basis. Whether they'll pay for it on an ongoing basis following an evaluation phase in the UK is yet to be discovered.
And is Sasha and are you the same commissioners cover you guys? Does the same principles apply to you in your hospital?
Same commissioners?
Yeah.
No, it'll be it's a different region, so I'm not sure whether they've spoken to each other, to be honest. Because the chief executive of our hospital has told us to get involved, we've not had to put a business case through, we've not had to justify anything. In fact, I'm completely oblivious as to what it costs. It's like being given the keys to a Bentley, full of petrol or whatever, for the rest of your life, or whatever the rest of the time that the Bentley's going to last for. You know, I've asked numerous times and I've not got any answer as to what I know how much the staplers are, but that's not what we're talking about.
If we put the issue of cost aside for a moment, clearly it is more expensive for now and will remain so for some time to come. Again, as a show of hands, do most people think this is an advantageous way of doing minimally invasive pulmonary surgery compared with conventional VATS, or do you think it offers an advantage or even a disadvantage? Who thinks it offers an advantage? Who thinks it offers no real advantage?
brave, very, very brave people.
May I say just one thing? We are, as European people, I'm sorry, but I want to stress this point. We started with a robot surgery, and with I shown as in the slide that there are some different centers in Europe, and especially mainly in France. We have 8 different centers with a very high volume. And I see that the UK started, and I'm very happy. And I hope that we'll start with the other center in a very short time. What I wanted to say, and it is just an invitation to the societies to be in touch with the other societies, probably with the national societies, with the Italian Thoracic Society, and try to organize a board for this specific issue. I believe it's very important, and especially I'm a friend of the American people, but they work in a different way. And this is the big problem for the company. Intuitive has a very, and probably J&J, has a different idea when they talk with us, with the European people, with the European surgeons. They try to apply the same way that they have with the American. This is maybe we need to stress the differences, and especially that we have a very huge number. Unfortunately, probably we don't publish together. This is the big problem.
Thank you very much, everybody. I think it's lunchtime now. So.